understand community-based research, participatory research, and stuff like that. But of course, it is not within its limitations as well. We need to strengthen our understanding of how ceremony, spirituality, and traditions are used in research. So although a large proportion of the articles reference the use of spirituality, the integration of elders, integration of indigenous knowledge, it doesn't always include a clear discussion of how that impacts the final results. And what I mean by that is that it mentions a guiding process, it mentions an integration process, but once we reach the end result, it is hard to then see again how these spiritual aspects shape the results of the results. And so there needs to be a further discussion then of clearly articulating how exactly which aspects of spirituality did it affect the final results of the articles. And so it further discusses how Indigenous knowledge challenges and shifts our understanding of how we conduct research. And simply beyond referencing Indigenous cultures, there needs to be an increase of reporting how research is integrated in research and how all of these things are conducted so that it aligns with Indigenous ways of knowing and doing research in a good way. And thank you all for attending my presentation. Yeah.
Thank you so much. You're not off the hook yet. Do we have any questions from the audience? How am I speaking? Of course, that's wonderful. Do we have? Well, it's just we're broadcasting so that the microphone makes a difference for the virtual connection. Thank you, Sandy.
Thank you. Thank you for your presentation. And I really appreciate all the work you've been doing and you've done. I find it perplexed for me as a Indigenous Métis person to understand where we fail to understand the effect of spirituality in research. We've been doing a lot of that in the last few years, and research on the land and things like that, and it is community research. But we say that our data is our oral data, and our stories is our data. So as a person who's done peer research in community and healing on the land stuff, the spirituality component is so important in grounding the people, the cohorts, and the research. So I don't understand where you cannot see how that affects in a good way your research. I'm just saying that from being perplexed, meaning no disrespect to anybody. But if some of the research, when you go into communities like the downtown east side of Vancouver, which it's a daily struggle for your living and where you're going to get your fix and where you're going to live and all that. When we take folks out of that environment and we bring them to the land, you get a total different perspective. And when you ground them in ceremony, some people start crying because they haven't had access to medicines or to ceremonies. So that's where I want to go with that. So if you can explain to me really the raw part of what it is that you don't understand around spirituality and cohorts.
Okay. So I approach this research first and foremost as a learner, as someone not of Indigenous descent. Indigenous ways of knowing and knowledge is something that I really had to learn by doing, learn by talking, learn through oral traditions, everything like that. And it's very true of what you talked about just now, that spirituality is ingrained within oral traditions. Speaking and coming to CAR, like speaking with elders, speaking with different community members, I can hear and understand conversations about spiritualities in these conversations. But when I was doing, and when the team was doing this review of the literature, a lot of the knowledge then is contained within the written text of academic peer-reviewed journals and articles such as that. So what you referenced there about spirituality, you can see the emotional connections, the raw emotional expressions. That does not get captured within these academic texts. And that's what I mean by what's missing there, because we plan to use these articles and these findings to develop workshops and stuff like that. So what we are trying to figure out, or whether or not this is even possible, is how to accurately communicate and capture these type of raw emotions within a written text, or exploring that avenue. Do you know what I mean? But right now, the written does not adequately express spirituality. And that is one of the limitations that we've discovered.
You good? If you want to follow up, Aaron will be in the lounge. Have a good conversation. Thank you, Aaron. We have one more question.
Doris, I actually work at Beast, but I'm just wondering about the gray literature. I think there's important information contained in gray literature as well, and some of it captures the actual oral aspects, like stories in gray literature, and I think in terms of our decolonizing, I've seen within mainstream kind of academia or within mainstream research that gray literature is always put aside. And some of that gray literature is actually sourced. It comes from the community. And I think as part of our decolonizing approach, maybe we need to reconsider how we treat gray literature. And you know, I've also heard years ago when we were putting together the status report on with PHAC, the women's HIV status report with them. There was great discussion about gray literature about including it, and they did include it, aspects of it, but I too am a little perplexed, to use one of Sandy Leo's words, that gray literature is often put to the side because does it not measure up to the evidence or that's written about in articles or publications?
Doris, thank you so much. I think that was a really, really important statement. It was there, I think maybe Aaron, so I'll kind of mindful of time suggest that that's a really important finding, right? That supports the recommendations, that there's more that needs to be, and I think builds on what you've shared as well, Sandy Leo. And Aaron, bringing your learner stance and your commitment to learning, I think is this is part of that learning. I think. Thank you. Okay. Tim, I'm going to pass it off to you. Now that you're here, thank you. But you're only going to be on screen if you're up here.
Just like to thank my colleague Renee for taking my spot and starting this session off, because if I leave this room, I get accosted into other meetings, so I'll stop doing that. So now we have Renato Molina and his team to present virtually. Yes, we're good to go. 2 seconds, so I can fill that. Tell a joke. No. That's the cleanest joke I've heard from you. Thank you. Thank you for keeping it PG. Okay, we're ready to go. Renato, if you can introduce your team, that would be great. Thank you.
Yeah. Oh, okay, there you go. I'm unmuted. Hi, everybody. I'm Renato. My team includes Elder Sandy, Tyler Craig, and Claudia. I'll let Tyler do some of the introductions here before we get started. Tyler, do you want to speak a little bit?
Yes. Good morning. I'd like to introduce using my traditional name, which is P.A. Suawasis, meaning Thunder Child. It was given to me by a Cree elder. And we are from Kilala-Lalem, which means Butterfly House. It's a decolonized medical clinic located in Vancouver's downtown east side. And We are the research team that has been part of the Partnering with Indigenous Elders cohort study that we will be presenting on this morning. I'd like to introduce our elder Sandy Lambert, whose traditional name is Snuckus, and I'd like to turn things over to him.
Okay, probably everybody can't see me because I've been, my video's been stopped. There we go. I'd like to acknowledge the unceded ancestral Coast Salish territory of the Musqueam, Squamish, and Tsleil-Waututh people that we live, work, and play on, as well as we know that most of these people have been here stewards of the land for many, many years. As well, Kita Latum, I can't see the slides, but Kita Latum means, as Tyler said, it means butterfly house. It was first opened in 2018. It's a medical home model of care located in Vancouver's downtown east side. It's team-based primary care and cultural care. We have about 80 staff and we're growing, and there's about 1,369 members. 70% relate to as Indigenous, identify as Indigenous. Over to Renato.
Yeah, sorry to kind of interrupt our little talk here. I'm just wondering if we're able to share screens for because we have some slides here with us.
Yes, we're just going to put the slides up for you in a moment.
Oh, I have power to share. Awesome, thank you. And can folks see that?
And you're good.
Amazing. Thank you so much. And thank you, Elder Sandy, so much for the introduction. Really, what Kalala Lela does is we are a multidisciplinary, interdisciplinary team that our entire clinic is elder-led. We have elder input on all aspects of the things that we do. Kind of the three main branches really are our primary care team, a relational care team, which is like also a mental health care team. And we, as you can see in this picture here, really at the center of our medicine wheel are the members who we care for. And that is done with a shared respect, understanding, communication for achieving those goals that our members want to achieve. And this kind of developed from originally from Vancouver Aboriginal Health Clinic, or Kalala Lelam, became operational. There was a study that looked at the partnership between elders and physicians in allowing folks to find a place of healing, being able to gather strength in cultural identity and using that to find a place of belonging and develop trust in opening up and coping with losses. And all of that is done through engaging in ceremony and the spiritual dimensions of care with the help of the elders, which is so critical to the work that we do. And this kind of set the precedence for the Partnering with Indigenous Elders study. And really, the reason this study is taking place is because of the three main points that are listed on the slide. One of them being the disproportionate effect of the ongoing opioid crisis, how opioids have become increasingly more potent, increasingly more available in the downtown east side community. And as a result of colonialism, racism, and intergenerational trauma, Indigenous folks are disproportionately affected. What we are trying to do is building those inroads to culture and allowing culture to save lives and really connecting folks with the ceremonial aspects of culture and really kind of tapping into that wealth of knowledge that elders have for all the different diverse healing traditions that are found along First Nations communities. And so our research goal is really to look to try to connect these folks and have that reduce their ongoing use, both from a dollar amount perspective and the number of days that they use per month. And this is directly in line with our advocacy goal to support the TRC call to action number 22 and recognizing the value of Aboriginal healing practices and using them to treat Aboriginal patients. So a little bit about our study description and our study design. I kind of already touched on the research question, which is really connecting elders with members at our clinic to try to mitigate the impacts that ongoing opiate use has. So we have a prospective cohort. We have right now recruited 52 participants. There's a quantitative and a qualitative component to the study. The quantitative component has 4 visits: baseline, 1, 3, and 6 month follow-ups, where we asked folks about their ongoing housing situation, how stable it is, their ongoing use of substances from alcohol, cocaine, opiates, and amphetamines, as well as aspects of the medicine wheel, which is the spiritual, mental, and emotional and physical health, as well as their connection to culture and community. Along with that is the qualitative component. And I'll let Tyler talk about that later on in the presentation, and as it is a big component of the research that we do. But in short, we are trying to highlight and explore the relationships that members have with the elders, and seeing how that is affected along the length of the study. And the other aspect that we're including in this, because folks who use opiates have access the emergency room more frequently, we are including a 12-month pre and post analysis of folks who are enrolled in the study to see how often they utilize the emergency room during the duration of the study and year before and after. Sorry, 1 second. I'll let Claudia take over here. Claudia.
Thanks, Donato. This is a brief snapshot of what our participant demographics and what the cohort looks like. So we see that over half of these study participants have had 1 or more parents attend residential school or Indian day school that they know of. Again, a majority have direct experience with foster care, either as a parent, as a child, or both. A majority, again, have experienced an overdose in their lifetime, with about 10% having experienced an opioid overdose in the past month. 65% have completed high school, some have gone on to trade school or post-secondary, other types of post-secondary education. Slightly less than half identify as women, and 2% identify as two-spirit, and another 2% identify as non-binary. We have 32 First Nations communities represented in our cohort from all across Turtle Island, with pretty strong Cree, Saulteaux, and Ojibwe representation. So this is kind of a brief snapshot of some of the responses that we've received. We have some preliminary results to share. We do have quite a bit of surveys to complete. So we have a per protocol analysis, which essentially represents folks who have completed the surveys and participated in every single survey and visits with elders or cultural circles or both. So we see kind of a slight decrease in opioid using days, but that's not really our most pertinent finding to date. What's really been the most interesting is the average amount spent on illicit opioids, which for those who have engaged with the cultural wellness program in-house at Kilala as part of primary care, as part of routine primary care, see on average a 41% decrease in their daily spending. So $36 to $21 over the course of 6 months. We also have an intention to treat analysis. So this captures folks who, did not maybe complete every single survey, or for whatever reason chose not to participate in the cultural wellness program after enrollment, which of course being member-led is kind of happens by their own choice and at the frequency that they choose. So we have also, followed these folks and provide resources and support for them, and the door is always open. But so far we've seen, a marginal decrease in the average spending and as well in using days. But we'll see when the study wraps up. So there's only 9 folks in each of these analyses so far. So they are quite preliminary, but the amount spent seems to be kind of the most significant change so far.
So one thing that I've been hearing today is about spirituality in the context of research. And it is next to impossible to quantify in a quantitative form what exactly the nature of an interaction with an elder is, because it is a very spiritual experience. We are looking at something that is grounded in the ancestral traditions of our people. And so to be able to properly honor the experiences that our participants have with elders, we are employing the two-eyed seeing approach to our research. What this means is we're, of course, following the academic standards that are expected of us in a research study, but at the same time, we wish to honor the traditional form of storytelling that is so prevalent within our cultures. I know in my culture that storytelling is very honored, and so this is the rationale for the qualitative portion of the study. And so what we want to do is not only ask about the nature of the interaction and what happened, but we want to learn more about the background of our participants. As has been mentioned, many of them have been in foster care. We are also gathering data on the number of participants that have been part of the 60 Scoop. So one thing that we know is that a significant number of our participants have never had previous experience with culture. They're in their starting phase of their learning journeys. For some of our participants, the interaction that they've had with the elder as part of the study is the very first time that they have sat with an elder or been part of a cultural circle. So this is a very important part of this. And then, so we are gathering 12 stories. And right now we've done 8 interviews. And, we'll be doing the coding, and this looks to be a very promising part of our research. And so I'll pass it on. And then, yes, and then to the limitations and retention. Oh, yes, sorry, I apologize. So this is the case example of one of our participants, JR, 42-year individual from Saskatchewan. We've obscured some of the details to protect this participant's privacy. From the 60 Scoop, never had experience with culture. This person moved to Vancouver from Saskatchewan because they became HIV positive and wanted to access the healthcare services that were available. Unfortunately, they ended up in the downtown east side, and they have been there for about 12 years. Now, in the qualitative interview, this participant spoke about their experience with the elder and how the elder provided them with valuable insight on their life and relationship issues. Also, the elder performed some healing ceremonies, which the participant was very receptive to. As a result of this participant interacting with the elder as part of the study, this participant is continuing to express interest in working with an elder to be able to continue along their spiritual journey. So at this time, of course, I'll pass it on for the next person to share on the limitation section.
Thanks, Tyler. So some of the limitations, it really comes from really engaging folks and trying to get them out to make their cultural events, because everyone, we do have honoraria, so we do pay our participants for completing surveys. But one of the biggest hurdles is really connecting folks with the culture and having them come out. So folks are busy, they have their own lives. And on top of that, having many different appointments to many different healthcare services, having that extra burden of another appointment can sometimes be a lot for them. So we try to be as accommodative as possible. We do outreach, we do accompaniment to not just appointments that are research visits, but their primary care appointments. So our research staff is really we are accommodating in terms of we fill in there's cracks in our clinic that where people get kind of lost, they fall through cracks. Our role is really getting in those cracks and making sure that people are connecting where they need to be connecting. So we offer that support, doing up, and that includes things like revamping some of the cultural wellness program flyers, telling and showing them a little bit of the info about our cultural wellness program, coming to their homes if they allow, and just having a chat, going out for a coffee, meeting them where they're at. So a lot of the work is relational as much as it is research of what we do. So I'm going to go here to the next slide as we're running out of time. And Tyler, do you want to take this one?
Yes. Our knowledge translation, our knowledge dissemination is going to be vast and broad. Part of what we're doing this morning is a little bit of our knowledge sharing. And so our target audience, of course, is going to be first and foremost the members of our clinic. The knowledge that we gain first and foremost belongs to them, and it belongs for their benefit. And that's a big reason why we want to do this study, is to be able to allow our members to benefit from this study. Of course, we are thinking about the community members. We're thinking about clinicians, both within and outside of Kilala Lalem. And we would like to, of course, reach out to researchers and policymakers in the hopes of advocacy, as has been mentioned. Our model of care is something that we'd like to be able to share on. So as part of our strategy, we'll be holding community gatherings within our clinic to our members in a cultural way. We'll work with our cultural wellness team. We'll be submitting publications. We're presenting at conferences, both local to Vancouver and nationally, such as Cannes. And we will be sharing on publications with health authorities, federal and provincial, and local networks to be able to provide media exposure. And so I'd like to give a special thank you to the Kilala Lalem elders. They first and foremost have guided us in this study. I'd like to thank the members of Kilala Lalem for sharing their time and their knowledge with us. And would like to thank our staff at Kilala Lalem for the support that they have of our study, for community members and for stakeholders, internal and external. And I would be remiss to fail to thank my co-workers on the research team, both that are presenting today and those that are not part of the presentation. Too many to count. So thank you for listening, and certainly we can pass it over for some questions.
Are there any questions here in the room that we can ask them? Yes, Rick, just a moment, we'll get you a microphone.
wondered if you could, if our presenters, some of our presenters could talk about the challenges of involving people who are very marginalized and distant from agencies or outside your sweep. Does that present as a challenge? Do you feel you're getting the kind of information you need to do the kind of study and have the appreciation you have? From personal experience, I have a First Nations adopted family who are not near to agencies, who are literally dying every few months from opioid use in Regina. So I don't think their voices are included because they're very distant. So do you go to the places these people live, at the very edges of our societies and our cities?
I think I can field part of that question if that's okay with the team. Yeah, first of all, you know, I'm sorry to hear about your family members, and it certainly is a limitation to engage with folks who are disconnected from services. I used to work in outreach, and yeah, it's really hard work. We're, you know, quite central in the downtown east side, and since our participants are also members of the primary care clinic, they are, you know, somewhat attached to a service already. So that is kind of, you know, part of the representation of the cohort, is that they are folks who are attached to primary care. And so they're not, you know, it's not capturing the voices of folks who do not access services, whom there are a lot. Also not folks who live outside the downtown east side. It's quite hyper local. In terms of reaching out to the folks that we are seeing, who maybe go through phases of, you know, disengaging, engaging, which is very common for whatever reason. What we can do is outreach them. So, you know, I would say about half of my work as a research assistant is actually outside in the community, visiting people if they've given me consent to go to their homes, or maybe meet them at a park, or, you know, wherever they kind of hang out. So we do try to kind of bridge that gap as much as we can with the resources that we can, and kind of prevent losing folks to follow up for that reason. And, you know, of course we have this research goal, but it's mostly relational. If we can get them, you know, maybe to renew their medication or come into the clinic, and they're not interested in doing, you know, a research visit with us, but we can offer support in another way and connect them to another service, then, you know, we'll gladly do that. I think that kind of comes ahead of, you know, checking off a survey for us. Yeah, I hope that answers your question, but there certainly is, you know, a group of folks who are not, you know, their stories are not being captured just by virtue of the design of the study and working with folks who are already members at our clinic in a quite tight community.
I'd like to very briefly add to Claudia's answer here, is that in the qualitative interview, what we are looking at is being able to get a cross-representation of our members, which there is, of course, going to be individual stories, and it's not intended to be a representation of all Indigenous people, nor all people in the downtown east side, but rather the experience of our clinic members who may or may not share traits with them, but we are paying close attention to what themes we can look at in the qualitative interviews to be able to emerge that we hope will be relevant for agencies and researchers across Canada in their work with marginalized populations.
Thank you. We're getting nods in the room, so thank you.
Hi, my name is Jordan. I work at Manitoba Harm Reduction Network, and I had a couple questions, but they all kind of connect to each other. Firstly, I was wondering, so it seems like you're measuring data about kind of changes in cost and changes in use, and I was wondering if participants identified those as the harms they were experiencing, or how that was identified as the kind of data to measure. And I was also wondering if participants had an opportunity to identify like their own goals within this project. And then my one side question also is, considering that you were able to reach so many folks from so many nations, how, and I'm sure kind of the elders in your region are elders from the nations in your region. And I was just wondering how you kind of mitigated the kind of challenges in the cultural shifts, or if you consider that a limitation of the research, or if there's going to possibly be more funding available to get access to cultural care and elders that are from the communities that these folks are from.
I can speak to that quick. And Tyler, if you don't mind, I'd love to delegate this to you, because you, in the qualitative interviews, harms and goals might come up more than in some of the other questions, the quantitative components, Jordan, that you were mentioning. And so yeah, Tyler, I'll let you take over if you don't mind.
Okay, so I'm going to start with your last side question about the population that we serve. So in Vancouver, in the downtown east side, it has been our experience that many people have come from across Canada to the downtown east side for a variety of reasons. Now, we do find that we have Coast Salish people, which is the local Indigenous peoples in and around Vancouver. And so to be able to provide effective services, the elders and those that work in the communities are brought from a variety of backgrounds with a variety of experience to be able to help to connect to our participants. Now, one thing that I will mention about the goals and aspirations of our participants is in our qualitative interviews, we are asking questions along the lines of yesterday, today, and tomorrow. What was your experience before the study? What type of experience did you have with Indigenous culture? What was the impact of the visit with the elder or the cultural program? And then how will this help you along your spiritual journey? And all of those three elements together, we're able to get a good picture of where the individual is at in their spiritual journey and where they're going. And certainly this is being recorded. So Renato, I don't know if you have anything to add.
I would also
Claudia.
add that it's not a goal of ours to reduce anyone's substance use, either the number of days they're using or the amount they're using, and we're not trying to project that goal onto anyone. It's a very personal choice. And so it's observational amongst other things that we ask folks about their wellness in the context of medicine wheel teachings. And so we certainly don't, frame it as the objective to reduce anyone's use. It's really up to them. I mean, that might be the journey they're on and that might be their goal, but it also, it might not be. And for some participants, it's not, and that's totally fine.
Yeah, I would say our goal is really connecting with culture. That would be our goal. We don't like whether or not it reduces, exactly what Claudia says, it reduces ongoing use. That's not our main priority. Our main priority is connecting with culture, having those inroads, because a lot of folks in reality, they've been so disconnected from their culture, from ceremony, that they can't even grasp what it might mean for them to connect with culture. And then really once they're able to connect, we've had a few members who have been able to connect with members, and that experience is profound, and there's a lot of change that happens during that time. And sometimes it can be fast, sometimes it's slower. So it's really, it's kind of take it at your own pace, but with our goal being to connect to culture. Hopefully, Jordan, that answers your question. Thank you, Tyler and Claudia. That was really well said.
No, thank you. So we have one more question for you.
Hi, Cindy L. It's Cindy L. Thanks to the team for the good work you're doing. My traditional name is Kilela Slanai, butterfly woman. I too work in the downtown east side, so I have a couple of questions. I love qualitative research, so choosing 8 members in a clinic, I think you said you have 1,600 and something. Why that number for qualitative? And do you feel that that number is really truly representative of your clients or members who access your services? And the other thing is what did you do to recruit? Like, how did you recruit? Like, did you do surveys or applications? Was there someone in charge of your recruitment? Because I think those processes are also important in recruiting the members you want to participate. And what were your criterias for the members to come in? And the last comment is $36 daily use sounds low to me. As a consumer, my consumption was way up. And when I talk with a lot of our people downtown, $36 is quite a low number. So how did you arrive to that number? Thank you.
So I will answer the first question that you have there about the qualitative interviews. So I should mention beyond our slide is that we are starting out with an initial number to be able to, gain some insight into themes and what sort of stories are coming out from the data. Now, we are well aware that this is not going to be a full representation. So what we have done is we have done the first 8 people that have completed the study, that have had that meet the qualitative criteria, and we have interviewed them. Once we have our first 8, then what we are going to be doing is taking a more targeted focus to ensure that we have a cross section of our study, whether they are nations represented, genders, and so forth, so that we're able to gather a more comprehensive picture of our data. So right now it is unknown as to actually the number of participants that we will actually have, because we have not yet reached data saturation.
Yeah, and just to add to that, it really with the last one is the data saturation. We're looking at themes that come out through the thematic analysis, and what we really mean by saturation is really once sufficient enough themes come up that they become overlapped enough, that's when we will likely stop recruiting folks for the qualitative interviews. And just to speak a little bit more in terms of the recruitment and member representation. So this study in particular, we're looking at folks who use opiates. I wouldn't say that these folks are representative of the entire clinic, because at Kilala we have around 260 folks who use opiates, and that's out of 1,300 around 1,300 individuals. So it represents less than 20-ish% of our members. And in terms of the recruitment was really, we have an opiate use disease registry. So anybody who is over the age of 18 could provide consent in English. Was able to provide consent, and currently is using and has had no previous experience. Our main target was really looking at the inroads to connecting with culture. So folks who haven't been connected before was part of our recruitment criteria. And when it comes to the dollars amount, which I think is, you made an excellent point. which was that it's fairly low. I do agree with that, but the thing with the members and the way that that we recruited is a lot of the members who are part of the opiate use registry at our clinic, some of them are in remission, some of them have been on opiate agonist therapy for a while. And so they've managed, some of them just by virtue of chance, our recruitment happened to get likely some of the folks who are a little bit more stable on their opiate use. But I know for myself, I'm connected with a few folks on the study who are in the $150 plus range of amount of use per day, which gets pretty high up there. And so it's really a mixed bag of the people that we encounter.
Yeah, and those numbers as well is only the subset of people who have completed. So that's a very small fraction. I think the global average is closer to $70 a day. But as Renato said, it varies from 0 to 200 plus. It really just happened to be that our, the 9 folks who completed the survey and fall into that sample for the per protocol analysis.
Yeah, we still have lots of other folks to include. So that's very preliminary.
Yeah, it is low. You're right.
Yeah, it's a good catch.
Thank you. Did they capture all of your comments? Okay, thank you. Are there any other questions? Oh, we have a follow-up. Go ahead, Rick. So she keeps putting her hand up and coming down.
Yeah.
We'll call on you later.
Well, I'll try to make this fairly succinct, but the thought I have is that, and my own story perhaps, is growing up poor in Métis in a large family in the city and finding a way to survive in a dominant mainstream was non-Indigenous. I was adopted in a traditional way to a First Nations family some 30 years ago. And that relationship was everything. But the kind of talking that you're doing about understanding spirituality then, I was raised Roman Catholic, but I was brought to this spirituality and taken to ceremony, but I also saw how people lived in their homes and what was important to them. And I also saw then my brothers and sisters fall into deep addictions. And so that has changed me personally and has given me what spirituality I have that's Indigenous, not only by birthright, not only by sensibility or blood memory, as our leader Margaret calls it, but also by these difficult and yet very real and loving experiences. I'm wondering, in your work in a clinic, how often you get together to talk to each other about how this work is changing you. Because this exposure will change you over time, slowly. And it'd be a really good thing that you share that and out it with others. So if you could tell us a little bit about that. It's not a criticism, because I don't want to make any assumptions. And I see some nods, so I'm quite sure it's something that's I'd love to hear about.
That's an excellent question, Rick. Now, we as a team, we meet every week to be able to debrief in a fairly standard way about where we are at in the research. However, what we have done is we have connected with the various clinic elders that we have. There's about 5 or 6 that work closely with the clinic, and we've invited them in about once a month to our meetings to be able to share with us traditional teachings and to allow us to be able to debrief our experiences with this elder. Our team members work closely with the elders to be able to share on their personal growth. I know for myself, I make a point of engaging with an elder once a week to be able to share about where I'm at in the study and my own personal growth. As a side note, we as a clinic will be doing a sweat lodge this weekend, and I know my team members are really looking forward to this experience. So I think, you know, these type of activities have helped us with our spiritual growth.
Yeah, and if I can add to that, Tyler, thank you so much. That was beautifully said. And thank you so much for the question. I think it's having reflection in terms of what it means, not just for the people who this research is for, but for us who are behind the scenes and working on this research. I have found over the last few months, over the last couple of years, incredible amount of growth. And that comes not just from what I learned in clinic, but in my own standing of my relationship to substances and what that means. I no longer see substances as, oh, this is terrible, this is bad. Substances, it's changed my view of them as something that people use to cope. It can be used in very different settings, and it can be using substances can be a spiritual experience for some folks, and so it's really having that room to reflect and just sit with what that means for members, what that means for myself, and just reflecting on that, and then taking that and bringing it back to the elders that I see once a week, and sitting down with them after a smudge and talking about what that means for myself, and being able to integrate that into my own personal journey. It's just it's work that's iterative. It doesn't end because we're always growing and always learning from ourselves and from the members that we care for. If anybody else wants to jump in from the team.
Sorry to interrupt, but I'm just cognizant of time. We have one more presentation. Thank you very much for sharing. Love the questions we got from the room. Thank you very much, guys. You can.
Thank you.
All right, so we have one more presentation this morning. Tanya Webkin from AIDS Vancouver is here, as well as my friend. I'm honored to call her a friend. Elder Sandy Lafambroise is here as well to present. If you guys can come up. And by the way, Sandy is sporting some of the new can swag.
Hi there. Oh, perfect.
Hi.
Hi.
We're just gonna adjust the camera so it's not me that's the spotlight, because we don't want to lose our audience.
Are we a go?
I think so. Good morning, everyone. Thank you for listening to and staying for us today. My name is Tanya Webking, and I am Dene German from the Tlicho Nation. I am also an uninvited guest on the Musqueam, Squamish, and Tsleil-Waututh people's land. So I try to work in good ways and to honor their work in protecting the lands. So I am very grateful to be here on Treaty 1. This has been an incredible couple of days and life-changing. I first came into the work in HIV research in 2005 when I was the project coordinator for the CEDAR project. So I do have some history in this community. So it feels like a welcome back. I joined AIDS Vancouver in September of last year. I had been out of Vancouver for a while, but I also do a lot of community work around tenant rights and anti-poverty work. And my bosses at AIDS Vancouver support that work because all of my efforts go to try to help my community directly. I'm co-chair for the Renters Advisory Committee for the City of Vancouver. Because I don't recognize a colonial border, I am the interim president for the Tenants Union of Washington State. And also running for Vancouver City Council. So very, very excited and proud to be part of a social movement of change. AIDS Vancouver was the first national AIDS organization, 39 years this year that we're celebrating. Very, very excited about that work. We have three main teams. We have our case managers that help people living with. I am part of the health promotion case management team, which is health prevention, so people at risk of acquiring. And then our peer support workers that help assist with getting people to appointments and other supports that they might need on an emotional level. Sometimes it's just going for coffee and talking because relationship is so important. Philip Banks is our executive director, and I'm very excited to say that he was one of the founding members of AIDS Vancouver, and he came back about a year and a half ago, and he will be moving on to pursue other things, but I'm very excited to say that what I see as his final big piece of work is helping AIDS Vancouver decolonize our structures and look at the ways in which we invite Indigenous people into our space. And his first move in that direction was by hiring a consultant who is Sandy Laframboise. So I will let you speak about your work.
Thank you. Hi, everybody. Most of you know me as Sandra Laframboise, my government name, but in community, I go by Sandy Leo. I'm acknowledging both the female and the male side, and it was a long journey to get there. And with a lot of tribulations and trial and tribulations and a lot of humility and humbling. Not easy, but about a year and 4 months ago, I was invited to come and help a tri-agency program called The Corner, which is a sex work drop-in center for males and transgender folks that are HIV positive. And so when they invited me, I says, well, you know my reputation, I'm pretty mouthy, pushy, and I will tell it like it is, and you may not like me. They said, okay, we know your reputation. So when I went in and they asked me to lead this committee, to create a committee, I said, well, I am for the people, and all I know is how to do it in sharing circles. And that's what I'm going to do. Start sharing circles, doing land acknowledgements, which I've received the rights to do through my adoption in Kalis, in Tsleil-Waututh Nation, and given the name of Kayla Santnai by Taha Amy George Sr. and Damien George Sr. of the Tsleil-Waututh Nation, to which there is land there that's made available for me to lead Two Spirit and Friends sweat lodge ceremonies, which is not their ways, by the way, but it's been adopted and many people do sweat lodges there. So what happened is in my discussion and in creating this committee, I said, I don't like the word advisory committee. It's so colonial. So let's ask the members what you want to call yourselves. The Caring Members Community. So CCC, Care Community something, I can't remember the last word. And they've decided that this drop-in center should be like a living room where people come and feel comfortable. So that got me thinking, what's a living room like when you come to a living room where your relatives are, your peers are? And so food was important, and more than just snacks, and more than just little finger food. So meals were very important for that meeting. And so we established that and got funding from the three agencies, and I started doing that meeting once a month and representing the members, and I was not shy of pushing the boundaries. And we developed, listen to this, terms of reference, which is something academia loves. And I went, oh, I hate those words. So let's call ourselves something else. What do we do when we come together? We behave in ways that we've agreed to that's socially good. So why not call terms of reference ways of being together? Why not changing that wording? And I struggled with the team for that for about 6 months because they kept calling it the advisory committee meeting. And I said, you know what? You guys pay me quite a lot of money. And if you don't want to listen, that's your trouble, not mine. So go ahead, continue doing your shite. I wasn't that polite, but I will do what I'm doing because you've hired me on a contract. So they listened. They finally listened and we separated. So what they want for their tri-agency participation, they call it whatever they want to call it. And we call our quote unquote terms of reference as ways of being. And we use a medicine wheel perspective, centering the members as the middle of the medicine wheel. And we went around and what is it that you want? You first come in, you're exploring your language and your ways of being together. And then what's the second one? Well, you've gotten used to each other by then. So what do? You start thinking about things and you develop things and the third part is you open the door and you send out your stuff. And the fourth part, it comes back and says, auntie, grandma, this doesn't work. Let's change that. So that's what we did with that committee. And it's doing really well. We have 9 people who attend. They're provided good meals and incentives to attend that 1 hour. It's a $40 card for food or for whatever they want. It's a Visa card. And then they said, oh, we want to do more. And I'm going, okay, well, I'm not going to work without having established protocols of the First Local Nations. Oh, do you know anybody? Of course I know people. I'm a member of the Musqueam Two-Spirit Collective. I've worked with the Tribal Council on Squamish, and I know relatives. I have relatives on Tsleil-Waututh, so I contacted them all, and we've got a council of 3 elders at AIDS Vancouver, that one from each nation, and they're responsible for our protocols. So we go to them when there's questions about protocols and how to do protocols for the local nation. Because at the end of your work in wherever area you are, what's left when you finish your work? Number 1 protocol is relations, relational protocols. So we got that. And after 2 months, I went, oh, we need more things. And they went, oh no, how much is this going to cost us? I said, not much, $50 an hour per person. Oh. So we decided to have a advisory committee because that's not my language. That's what they're calling it for now. I'm going to change that soon. I'm going to push for the change of that language and see what the members want. And so this committee comes together every 2 weeks, and it's made out of our Indigenous person. And we just hired an Indigenous peer support worker, all at my recommendations because of the connection. Who says we're not in conflict of interest when we're all related? So it's pretty hard not to do things in that way, right? In knowing someone and pulling them in for who they are. So we got now 2 Indigenous people, different people, which is great because I'm for bringing in as many people as we can. And from there, we developed the sharing circles, one for Positive Women with a female elder of the Downtown East Side, and one male group that's starting this week, Positive Male, and from an elder from the Squamish Nation. And just before I left, we started Bannock and Coffee. So people come in to get services or do their groceries, and they're invited up to have Bannock and Coffee. I've also brought in somebody to do Indigenous crafts every week. So that's my cousin from my home reserve, because I'm Métis, I'm Algonquin Métis, and it's been working well. People, even the workers now, are at a spot where they're saying, it's about time. It's about time. And we've had one person crying at the craft table saying, I've been coming here for 25 years and I've never seen this. I have never seen this. So the other thing we've implemented in September, just before we hired you, we wanted to kind of get a knowingness of what was needed. And so we, again, did some advertising and pull in folks, to Indigenous folks, to do a sharing circles and tell us what it is that they want as an organization. Also, this is all in 1 year, by the way. Also, we've done a cultural safety training and cultural awareness training with the board, the staff. Are we doing it with the volunteers, or has it been done?
Not to my knowledge.
Not yet. Okay. And the next step in that is Indigenous governance for an entire agency. We're lucky because Philip Bank recognized that in the 39, 40 years that AIDS Vancouver was in existence, it did not serve well the Indigenous communities that they reach out to. And so that's an important part. From the get-go, it was Indigenous people doing it for Indigenous people within a white organization. It's really hard because people hold on to their little titles and their little positions and they feel threatened, and here's this consultant coming in and telling them what to do. But now I have Vancouver Coastal Health interested. They're going to start a Bannock and Coffee program and they want smudge in their clinics. Back to you.
Okay. So you can see what one strong elder can accomplish in a year. It has been incredible to step in that space, but I just want to remind everyone that we have lost so many valuable services in Vancouver. Healing Our Spirit is gone. The Red Road is gone. Red Road that worked with youth is gone. Women's Positive Network is gone. We are standing alone in this work in Vancouver when we do have intersecting pandemics. As a health promotion case manager, yes, I do work in the office to try to do those referrals. Obviously, cultural work is central to the way that I work. So I need to be with community. So I am out on outreach all the time. I'm in the SROs. I'm in all of those agencies. I've been working in the downtown east side for 25 years. I started advocacy, mental health, addictions. I used to do healing circles for court diversions for Vancouver Aboriginal Transformative Justice Society. So I'm really in the work. This is where I feel at home. So the gaps in services are incredible. The safe supply, BC declared an overdose crisis 6 years ago. They declared it 6 years ago, and over that time, toxic drug deaths have gone up 400%. 400%. So because I'm also a community organizer, I do a lot of unpaid work in my community. I have these conversations with a lot of different groups and a lot of different people. And we have to address that. We have, the downtown east side has the lowest life expectancy rate in all of Canada. The downtown east side has the highest incidence of IDU users with HIV prevalence at 27%. This is a crisis. When we talk about safe supply, what I like to talk about in my circles is, because I work with injection drug users, we have been fighting for safe supply, and the city of Vancouver has actually endorsed this idea. They have endorsed this idea and they support this idea that is from organizers prior to my work there. That's important, but who is stopping us? The federal government. They will not step in and make this emergency change. I spoke yesterday while we were in some groups, and I want safe supply, because if we have safe supply and we remove injection drug use, that can remove an entirely a risk factor. So I really, really need us to push for safe supply Canada-wide, because that could save thousands upon thousands of lives a year. So because I'm in outreach all the time, I'm in the SROs, the single room occupancy. If you have never been in these, I have been in them for 25 years, and they have somehow gotten worse. I am always doing a call to action to all the other frontline workers when I'm out there to ask them to get involved, to join us in community work, to not be tainted by capitalism and only do work for a paycheck. We have to stand up for our clients, because we are the only ones that see the lives and the conditions in which they live. People are dying and getting traumatized by living in colonial housing that is being provided by them, and that is not okay. I see the direst effects of colonization every day in my work, and I'm a 60s scoop survivor. It's really important for me to be able to have really real conversations with my clients. They feel safe talking to me. They know that I understand how it feels to be separated from culture. They're very damaged by that, and that's why the journey is not to say, you need to go do this, let's go do this, to invite them in. It is a real tragedy that people just drive by every day, and it needs to be highlighted. I get direct support from my clinical supervisor. We meet twice a week. The stories that I tell her on my journeys is very, very harmful emotionally. And my relationship with the Creator is central to my work. My prayers and my smudge before I head to work. I use my Sister Sage smudge spray in my office before I go to work so I can go into it in a good way. I spray my mask so I have that healing medicine with me in each breath. And magical things happen. I find clients that someone has been looking for a year. Someone isn't there, and I know where I can find my next client. AIDS Vancouver serves over 7,000 people a year, and we have a strong volunteer force of over 200 people, which we would never be able to do the work without. They are a vital piece. I am so hopeful. We are so underfunded, and we are holding so much of this work. What I'm going to say next is going to be shocking. I am the only Indigenous health prevention worker in HIV/AIDS in Vancouver.
No. At AIDS Vancouver. No.
At AIDS Vancouver. So we definitely need more workers that are Indigenous. Over 30% are Indigenous in the downtown east side, and Vancouver dares call itself a city of reconciliation. I'm ready for some reconciliation. Masi Cho, OCM.
Thank you. We're gonna, since she's asking for money, we'll pass the hat after. We just take a small agency fee on that. But thank you for sharing that incredible work that you're doing in moving forward and moving agencies to really adopt culturally appropriate care for our people. Thank you for doing that work. Do we have any questions for our wonderful team up here?
Good.
If you're too shy to ask questions, Sandy Leo, and I apologize for not calling you Sandy Leo before.
No problem.
Sorry. I would like to, they'll be around all afternoon. Find them, talk to them. More than willing to give you some time and their thoughts. So thank you very much for being with us this morning. Couple announcements to make. Lunch will be served soon because that's important. Also, the question on the flip chart, please answer it, or I'll stand out there and make you answer it. And also on your feed loop apps, please give us the feedback on that as well. All those roll up and that becomes our report for this, which helps not just our agency to keep on doing these events, but also for other agencies, because the work we do together is very important in moving policy and people into action. So thank you very much for the morning, folks.